Okay, so like we discussed yesterday as well, we're going to follow a very simple pattern for a facelift. We're going to do a mini lift, a sparse lift. Let's not get confused into anything else. You know that the entire covering of the face, everything that is covered on the lateral aspect of the face is the sparse, which gives the integrity of the face intact. Down below, when we're talking about the retaining ligaments holding on to this sparse, okay? The sparse, all these categories that you will find will be collapsed. Will be collapsed immediately down below, making your jowls. So you'll have to find in an intact person that you're doing, there will be a collapse, but you will be able to find it much easier. So incisions, we're going to take a conventional pre-auricular incision, but the extension, you can take it into your temporal hairline. Here, the categories don't really matter, but you try and restrict that incision to 3 centimeters above your zygomatic arch. Okay? And that is the conventional facelift incision. Try and keep it as close to the tragus. And keep a cuff of about 2 millimeters so that you can get a good suturing there. You can approximate your skin margin without any loss of continuity. Okay? So we can just try and run it forward. And no, the initial incision, let them see. Into the post-auricular area, you want to be clear of your lobule by at least 2.5 to 3 millimeters. No tension close to the lobule. And after that, post-auricular area as well, if you see the cuff of tissue that I have, that is again about 3 millimeters which I have kept, you're not going to come closer than that to the auricular area. Okay? Because there is too much tension, the skin is very thick there, and you're not going to get good results there. To get good results in the post-auricular area, you need free tissue, which you can actually resuspend to a higher tissue. For anything on the face, it is all about resuspension. From a lower plane to a higher plane. The higher planes are not going to shift their position. Like we spoke about the temporalis fascia, right? The position of the fascia will remain where it is. So you have to take a good bite there because that is not going to change. Also, the sparse moves medially because of the lateral parapetomastoid fascia. The sparse is immobile; it is not going to move from there. So that is why the jowl is primarily found in this area because that is where it all collapses. So our main simple explanation is we're going to resuspend the sparse superolaterally to your fixed tissue, which is going to be the temporal tissue. Clear? No two ways about it. This is all that you're going to do, and this is. Sparse lifts are the most common facelifts pan world, okay? And it caters to almost all the kinds of facelifts, right from your 30s to your 40s, even 50s, we're doing more of sparse lifts. But one different variation that we do, other than just resuspending and suturing the sparse, we are going to do an incision on the sparse. Now what is this incision? This incision is, okay, let's move on. So don't get confused, okay? I know there's a lot of things in detail there, but the simple thing is a sparse plication or a sparse lift with a sparseectomy is what we're going to do. And it is the most common variation of the facelift. It is a variation of the mini facelift. Okay, a standard facelift these days is the most uncommon procedure done because the scar is never hidden. Okay, and in a male you can't do that, it comes into the hair. So this is incision. So we can move forward. We've done this today. So we follow the same thing, except we will keep our incision pre-tracheal by about 3 millimeters. Understood? We are not going to take an incision because it becomes a problem for the plane to take it forward in our S-shaped curvature, and it's an S-shaped incision that we're going to do. Okay, move.
You want to stay at between?
We're going to start subcutaneous.
Below the subcutaneous.
We're going to start subcutaneous. And we start from the suprazygomatic arch portion. Why? Because it's the easiest way to dissect down, rather than starting downward. Clear? Okay. Can we start this a little further? Because, okay, what am I marking here? What do you think I'm... What? Zygomatic arch. So first I will mark is the superior portion of the zygomatic arch, right? And then I will mark the inferior portion. Why am I doing that? Because I should be clear with my bearings. I should be clear where I want to resuspend my tissue. Another simple thing that you need to keep in your head very clear is resuspension does not happen without a stable base. Even if you do any kind of resuspension or suturing, you want a stable base, either a ligament or a tendon. In this case, we would either use the mandibular angle or the zygomatic arch, because every kind of lifting, am I audible?
Yes,
sir.
Every kind of lifting has to be superolateral, and it has to be pulled vertically rather than horizontally. Why are we not pulling horizontally? It will not just broaden the face. It is not going to give a lifting effect. It is just going to give a lateralization effect. The patient is still going to look aged. For a younger face, you have to uplift the face. That is why resuspension, supero and mildly lateral. Okay? That is the superolateral muscle. Okay. Okay, thank you. Let's move forward. So my minimum distance which I keep between my superior extent and my inferior extent is going to be about a centimeter, because I am expecting my mass to have collapsed way below the inferior portion of the zygomatic arch. So that is my second marking. And that second marking is actually going to be parallel to the corner of the mouth of the tragus. The first mark is the upper portion of the zygomatic arch. My second mark is tragus to the corner of the mouth. And you follow this vector because that is exactly where your mass is going to collapse. And you want to resuspend it to the higher portion or to my first line, point A and point B. Okay. Descend and I move forward. Now I am going supraspans. You see my first listing. You can either use the top portion of the zygomatic arch to the ala, and the second portion from the tragus to the corner of the mouth. Clear? Okay. So we will all mark before our dissection. Let's run it forward. Now this cadaver, if you see, there was a good amount of mass there. The good amount of fat layer there collapsed, but you can still see everything covered with sparse already. So we move forward, supraspans, that is we are on top of the spans, but the most important thing, we have a good cuff of 2 millimeters on our skin flap, okay, of fat. Because if you thin out your skin flap too much, you are going to create a dehiscence and severe dimpling on the entire face. So it is okay to be a millimeter or two deep, it is not okay to be a millimeter superficial. Understood? And this is one mistake that you can't make with even a subcutaneous facelift. Clear? So I'm not going to confuse you what a subcutaneous is. Subcutaneous is only skin flap. You are just excising and resuspending. We are going to do a skin and sparse plication flap. Okay? Move forward. So my extent here, okay, run it forward. This incision is very important. I am going to preserve as much of tissue around the lobule, because this is the biggest devastation of a ixia that forms post facelift, and it is very common. This happens if you pull the face laterally more than superiorly. And if you see, my posterior auricular skin flap is in a manner, it's quite curvilinear and S-shaped, right, in this extent. But from here I will move forward because I want a lot of tissue excess, and this entire extent is, you can have modification here. You can keep it as high as possible depending upon the amount of laxity in your neck. Okay? And here, and it was a cantilever, so whatever laxity you want, you can get, and you can dissect and cut and resuspend. Why I want to keep my extent higher is because the posterior auricular the muscles on the superior aspect are very taut, and the tissue, the fascia that comes here is again like the temporalis fascia that we get in the zygomatic area. So resuspension to a fixed tissue here is easier. If you come lower, this is also mobile skin flap with subcutaneous tissue. So higher extent is better. Clear? Okay. Yeah, let's move forward. So, going right now, I'm going to enter my practice now. You can see from the subcutaneous tissue. You can see the sparse, which is covering the parapseudomasseter fascia, which is accumulating towards your masseter area, the angular area. And you're still on top of it while entering your platinum. And why do you want to go into the platinum plane from here? Because my aim is See, even if I do a submental plication in the anterior vellum, by getting the anterior vellum, right, bilateral, I still have a lot of tissue excess laterally. If I don't enter towards my submental area and stop laterally, because if I'm planning to do a lateral plication or a belly, the lateral part of pads to be sutured after resecting either pad or directly suturing them, I will still want, I have a lot of tissue excess on the lateral aspect, so I have to enter through the lateral plane. And most of my, please move forward. Most of my dissection is all blunt. I'm not cutting, I'm just sweeping. So this is the concept of knife and one. It's hardly any cutting till I get a plane and I move forward. Little forward, please. So I've already got a little bit of excess tissue, but that's not my aim. After this, when I plicate this mask, I'm going to create 2 incisions on this mask. The inferior portion, I'm aiming for reattachment to a superior plane. That is the time I will get more tissue, more skin excess. So after this, I do my markings again, which I marked on the skin. You just make sure that the markings are the same what you have on the skin surface. So basically, the superior part of the zygoma, the arch, to the ala of the nose. Mic is not working. And the other from the tragus to the corner of the mouth. Clear? So you will mark the same things on this mask as well. So I'm going to create 2 incisions here. Move little forward. Yeah, thank you. 2 incisions here. I'm going to do 1 incision here, 1 incision here. Take out the chunk of mask from here. Take some out from here, and lift this mask and reattach it. Okay? And I'm not going to descend through my spas anymore because it's already collapsed mask, it is going to be loose mask, you just need to pull it up after doing a spa set. So basically I'm cutting, yes.
So you are cutting and removing the smash there between those 2 lines between those 2 lines.
So that only then will you get an inferior and a superior.
And then you just reattach.
Reattaching the mask to a higher plane.
So what would be the anterior extent of this incision?
It is going to be not more than 2.5 centimeters. Because if you calculate your entire collapse, that is the vertical extent that it comes out to. Not more than 2 to 2.5 centimeters. Don't go across the entire plane, you're not going to find smash. You're just going to find the collapse nasolabial fat pattern. Yeah, let's move forward. So, that much of smash we have cut off. So I have a free extent down below. And I have a fixed extent with the temporalis fascia up above. So I'm going to just pull my mask which is collapsed down and reattach it to a higher plane. My choice of suture here is a PDS. Okay? And I actually use something like a string suture around it, and it is a continuous stitch that a running suture that I do around it. That is a little more stable. And yeah, that's clear. Let's move forward. Okay, let's move forward. Forward. And this is the time when you, before you do your skin excess excision, you need to mark 3 points. 1, the suprahelical portion, where it's going to rest comfortably over the helix, right? And the lobular portion and the pretracheal portion. You have to make 3 cuts. So when you pull this tissue, you have to make 3 marks there. 1 here, 1 pretracheal and 1 here, 1 lobular portion. And then you mark a vertical across how much tissue excess there is, and then you will cut and resuture. So if you are not sure, it's okay to cut 2 millimeters less rather than cutting 2 millimeters excess. You can actually take a go at it again as well if you think there is some excess. But this layer needs to be without tension, any tension, okay? Because this is going to be a final result. Post-op, what is going to happen? There's going to be a lot of edema that comes. The biggest fear here is the hematomas. The hematomas are bound to come. So that is why you can either put in drains Or if you're sure about your hemostasis, no drains at all. When hemostasis can kill your skin flap. So, I mean a hematoma. Clear? So got the basic concept of it? Any doubts? When you start doing it, you will realize it. Please ask me at any given point in time. Ma'am?